Finding a balance between a patient's beliefs and a doctor's mission is not always an easy task. When a physician and a patient or their family disagree on things like medical treatments or end-of-life care due to religious beliefs, it can be hard to find a common ground. That's why it's crucial to incorporate education and understanding into the mix when it comes to religion and healthcare. Joining me now are Dr. Gregory Capinos, a neurointensivist at North Shore University Hospital, Lynn Stoller, Assistant Program Director, and Reverend Mark E. Fowler, the Managing Director of Programs, both from the Tannenbaum Center for Interreligious Understanding, and Reverend John Mee Bay, Manager of Chaplaincy Education for the North Shore LIJ Health System. Welcome, everybody. Thank you so much for being here.
Thank you.
Thank you.
Reverend Fowler, I want to start with you. Tell me a little bit about Tannenbaum and what you do there.
Well, Tannenbaum is a secular, non-sectarian, not-for-profit. We're based in Manhattan, and our mission is to combat religious prejudice. And we have 4 program areas, one in which we work with teachers so that we can prevent bullying that's bias-based or identity-based. One program in workplaces where we can work to make sure that workplaces are inclusive of religious beliefs and of non-religious beliefs. Conflict resolution program where we support and study the work of religiously motivated peace activists. We call them peacemakers in action, in active conflict zones like Nigeria and Syria around the world. And our healthcare program where we work with medical providers, both those in practice as well as those in training, to give them the skills and the tools that they need to proactively and respectfully interact with patients around the decisions that they're making based on their religious beliefs and practices.
So much about what you do is really about education and religious awareness.
Absolutely.
So Lynn, this was not always a part of the healthcare system. We didn't always consider patient spirituality or religious beliefs in dealing with patients. What happens when we ignore the spiritual needs of a patient? What goes on with people when this happens?
I think if we ignore the spiritual or religious beliefs of a patient, we're ultimately missing out on a huge part of what might define that patient in terms of the decisions that they make, their values, and their priorities. And especially in the United States, where the vast majority of Americans believe in God or some form of a higher power, so over 90%. And that means that the majority of patients that are coming through the door are going to be accessing, looking to their religion, their spirituality, their faith in some way, whether it's about the healthcare decisions that they're making or simply how they define respectful care in a healthcare setting. So it could be anything from a patient that has concerns around modesty and is having a physical exam done, or a patient that has decided, that is diabetic and has decided this year I want to fast for a religious holiday or a holy day. And what might that mean in terms of their health if they're not having a conversation with their healthcare provider? And then finally, when you're looking at someone that's going through an illness or injury, their faith can really be something that they want to look to access and lean on as a source of support and strength.
We might not think about it, but probably in the healthcare setting and with patients, this issue is probably more important than we've ever really talked about before. So you talked about these 4 areas that Tannenbaum works with. Do you think that we've pushed the needle forward in terms of education when it does come to the healthcare system?
I think we are pushing the needle forward, but we're also doing that very slowly. Tannenbaum has produced a number of educational resources over the last 5 years. We published a book called The Medical Manual for Religio-Cultural Competence, which makes it much easier for medical practitioners to get a head start on addressing the needs of patients. We have a CME that we created for doctors. We've created educational curricula for medical students and for residency programs. But one of the things I think that will make a difference is the ongoing recognition that this is a critical part of care. One of the controversies, if you will, is there are some people who recognize that the religious beliefs of their patients and the ways in which that it affects their decision making is a critical issue, but they don't necessarily have the training that they would like. Yeah. And then there are still some people who do not believe that the religious beliefs, or even the non-religious beliefs, and how those are impacting a patient's decision making is something that they should even bother with. And so as long as that controversy keeps going on, then what efforts we make sometimes will get diverted.
When I was in training, this was a non-conversation. We always believed that medicine was over here and religion was over here. And the truth is, Reverend Bay, it's not always on the same side. So how do you deal with physicians? How do you deal with educating physicians and patients and the chaplains in addressing this issue?
I think medicine and religion speaks different languages, that's for sure. But we all need to know that we have the common goal, which is to understand the patient, what's important for them.
There's a common goal that we're trying to reach, and it's just really connecting the words, making that language clear.
Yes, chaplains consider our work in healthcare as translation between the word of the patient and the word of hospital medicine.
As a neurointensivist, in no other place is it more prevalent than where you are, dealing with the issue between maybe what the family needs or wants from the spiritual or religious perspective versus what the doctor thinks is best for the patient. How do you reconcile that?
We want the best for the patient, and both camps are on the same side. The problem is, the words we use, and sometimes when actually, as you pointed out in your question, actually the family is actually not having the best interest of the patient in their mind, but they have their own needs because they're facing a very dramatic event, an event like a traumatic brain injury. A young patient suddenly becomes a victim and they never had a discussion about their values. Suddenly the family has to be facing that very difficult situation, and they are not grieving, but they are like in pain themselves, and therefore they are blurred and they put their own needs to be recomforted, feeling like we need to do heroic measures, we need to do everything just to feel good themselves. Yeah. When actually we need to, as a doctor, we always during those discussions reorient the discussion towards it's not a matter of like what medicine says and what faith is telling you and what you want. No, all those things are not even on the table. What we should really talk about is I understand it's difficult for you, but what is his values, right. As you said, the religious and non-religious beliefs. Tell me more about what he wants, or he or she, your loved one, or what do they want, what defines them, and then we will make a decision based on those values.
I think it's so interesting, and I think we're all sort of saying this. At no other time is this issue more heightened than the end-of-life issues. And certainly when a family has not had the opportunity to talk to their loved one, but the family really tries to hold on to their spirituality, to their religion, what they believe is the best thing. But the conversation isn't necessarily about that, although we need to be sensitive. It's about what's truly best for the patient, right? Mm-hmm. And I love that it's really about translating the words so the patients get it, and the family's patients, and the doctor gets it also. But what happens at end of life when the family says, I want everything done? And as physicians, sometimes we'll know that's not the right thing to do. How do we have that conversation? I'm going to pose it to you, and then Reverend Bay, I'd love to know what you think.
I feel like a lot of family members, when there is a tension with the medical team, it's very rarely the opposite, but often it is the doctors want to do less invasive and less aggressive care, and the family wants heroic measures or everything to be done, including surgery and putting tubes in every orifice and undignifying that maybe last week of life of that poor victim. So when there is a tension like this, what happens is that they again think about what they think is keeping hope and delivering everything just to make them feel good. But actually we reorient the discussion with them and say again, no, we need to focus on tell me what he thought when he visited his cousin that was in a nursing home. What did he or she say when she saw somebody that was very disabled, like able to walk before, and then after an injury was not able to do anything anymore. What did he think about that level of very poor abilities?
Quality of life. You
What
really, you
yes.
really tried to address that issue. And Reverend Bay, when this happens, because it happens often, how do you talk to the family?
We chaplain try to offer non-judgmental and non-anxious presence to them, to patient and to family and to staff, and to help them identify what they need and what they want spiritually and emotionally, what is struggle they are doing. And also culturally they are struggling a lot. What is the best decision for them? Sometimes it's very hard to, sometimes family and patients has different idea about quality of life.
Right.
And for family, I don't want to lose you. I want to spend time with you even one more day, one more hour. And patient says, I don't want to see you suffering like this. I'm okay with my own dying and death. So chaplain hear what really they want and they need, and try to connect.
It's that common ground.
It's
Make
what's the common
conversation-
ground, and at the end, is of course it's more about their love and
Yes.
their life and hope, and so so connect the dots.
Reverend Fowler, do you think this should stay in the legal world? That we should talk about advanced directives, that this should be a legal document versus having this spiritual and religious conversation at the time?
Another part of that education can be talking with families about, in the event of something happening, what would you want? And talking about the importance, but also the machinery, if you will, of an advance directive and a living will. And what do these documents actually do? Who do you want to make decisions for you if you're not able to make them for yourself? And I think, to the point, the idea of the competing needs, we tend to think about at Tannenbaum that this is not just the experience at the end of life. It definitely is very dramatic at the end of life if there's been no preparation and if there have been no conversations.
And how do we push this message forward?
Well, I think that it has to be a multi-pronged approach. And the first piece coming in, which is the work that Tannenbaum does around education. So we've done a lot of work to try to push this form of education within medical schools, within nursing programs, so that this becomes an integrated part of how a healthcare provider learns to practice. And then also making sure that for those that are already out in the field, that they're having these conversations. We've been talking a lot about communication. So making sure that patients are aware that this is something that they can bring up and talk about with their physicians.
I think this conversation is one that we need to have more of. I think all of you are ambassadors of really sending this message out. It is so important that everyone understands this is not just about end-of-life care. This is about what you believe. And really talking to your family, talking to your doctor is so important. And from the physician's perspective, we've got to be a little bit more sensitive. I can't thank you all enough for being here with me today. And let's keep this conversation going. It's really important and worth it.